Chapter 54, Male Reproductive Problems. Okay, so please visit this YouTube video. It's a nice little overview of the male reproductive organs and how they work, so you can recap your anatomy. Okay, let's get started. So we're starting off with the prostate. Okay, so the prostate's primary function is to produce the fluid that nourishes and transports sperm. Okay, so that's what the prostate does. Here you can see the prostate is about the size of a walnut. All right, so here on the left we have a normal prostate. You can see anatomically it sits around the urethra. Okay, it sits right up against the bladder, and then it kind of wraps around the male urethra. So that is where all the problems come from. When you have an enlarged prostate, for whatever reason we're going to talk about, but it's the first thing it's going to do is narrow the urethra, and that's why these patients usually first present with urination problems of some kind. So benign prostate hyperplasia, BPH, very common condition, especially in older males. So most likely you've already seen a patient with BPH or you've read it in a history. So let's talk about what it is. So this is enlargement of the prostate gland leading to disruption of urine outflow from the bladder to the urethra. Okay, just like we just talked about. So the pathophys, they're not sure exactly why it happens. They think that with age, there's decreased testosterone, which creates a hormone imbalance with estrogen, and then that estrogen will promote prostate cell growth. So that is their theory, but we're not for sure. All right, so risk factors is going to be aging, obesity, sedentary lifestyle, diet high in animal protein, alcohol, erectile dysfunction, smoking, diabetes, and it runs in families. Okay, so some patients won't have any symptoms at first, but as soon as that prostate begins to get bigger and bigger, it's going to start compressing the urethra. So as it gets bigger and starts compressing the urethra more and more, that's when the symptoms will become worse and worse. Okay, so we divide the symptoms into two groups, obstructive and irritative. So obstructive is literally that prostate is obstructing urine flow. So those manifestations are going to be related to the urine flow. So decrease in caliber and force, difficulty initiating the voiding, intermittency, so they stop go, and then dribbling at the end of urination. Okay, so that's related to obstruction. Then we have irritative. So whenever anything's obstructed, then it becomes inflamed. It becomes upset, right? Redness, edema, pain. So irritative symptoms are related to inflammation and infection as a result of that obstruction. So those symptoms are going to have urinary frequency, urgency, pain with urination, bladder pain, nocturia, which is being up at night, peeing, and then incontinence. So if you have a patient that presents to the clinic or to the doctor's office and they're saying, it's hard for me to start voiding, like I can't, I'm pushing but nothing's coming out, or I have dribbling at the end, and then also it feels like my bladder hurts and I've been having episodes of incontinence. You can just kind of say, you know what, they probably already have obstructive BPH and it's probably inflamed in there. So that's kind of, easy way to a clue to get to the diagnosis. All right, so complications that can happen are going to be related to that stagnant urine kind of sitting in the bladder for a while, okay, because it's not able to empty out completely or at all. So then bacteria grows, it changes the pH in there, so these little stones can develop. It can travel up to the kidneys, this bacteria. So that's pretty much the complications related to BPH. Diagnostics, we're going to get an H&P. Okay, here's our first new term, digital rectal exam. We're going to call it DRE. So these patients will get a DRE so that they can actually palpate the prostate gland. We'll get urine with culture. We'll get a post-void residual urine volume. That's where the patient empties their bladder. We get an ultrasound to see how much, if any, urine is left in the bladder. And then here's a new test for us, blood test, prostate-specific antigen, PSA. Okay. Uroflorimetry studies. Okay, this is just another study. You can read about it in your textbook. It kind of measures the flow rate to see if it's normal or abnormal. We can also do a transrectal ultrasound of the prostate. So this probe is inserted in the rectum. It's an ultrasound, and it can directly visualize the prostate. Then we have cystoscopy. It's a procedure which we'll talk about in a minute. All right. A little bit more about the annual DRE, or digital rectal exam. So this exam is recommended for males starting at age 50, okay, who have regular cancer risk. So combined digital rectal exam and that PSA blood test, okay, every year after age 50 should get this annual routine checkup. Okay, medications for BPH. You may have seen these in your patient's chart, okay? You can go through them. This just tells you how it works on the prostate. So some of these medications reduce the size of the actual prostate, helps with the symptoms. It might relax the smooth muscle that surrounds the urethra, but maybe not actually decrease the size. So it just depends. Each one does something a little different. The treatment is based on symptoms, not the size of the prostate. So maybe you have a patient with this huge prostate, but it's really not causing that many issues. Maybe it's not quite, obstructive. So treatment again is based on the symptoms. Health promotion. So we want to, again, like I mentioned, do the PSA screening, do that blood test, early detection and treatment. So the Urological Association recommends men ages 55 to 69 have screening every 2 years. PSA wise, okay. When symptoms of prostatic hyperplasia are present, then they may need to do it more frequently. You want to avoid substances that increase prostatic symptoms, which is kind of interesting. These alcohol and caffeine can cause issues. So for example, the reason why you want to avoid alcohol and caffeine is because it has a diuretic effect. It makes you pee more. It can result in bladder distension and overactivity, so we want to keep that to a minimum. However, these patients should stay hydrated with water, okay, water, not caffeine or alcohol. And that is because we want to keep that bladder dilute. We don't want stagnant urine in there that can harbor bacteria. So we want to keep them hydrated so we can avoid that. So conservative management for BPH includes active surveillance, watchful waiting. So they don't do surgery or anything. They just get their annual blood test, their DRE, and then they can modify their lifestyle. So they can decrease bladder irritants, like we just talked about, caffeine, alcohol, artificial sweeteners, spicy or acidic foods. And then they want to avoid some certain medications like decongestants, anticholinergics, and so on listed here. And then we want to restrict evening fluid intake so they're not up all night peeing. Then we want to do bladder retraining. So bladder retraining is just, forcing yourself to go to the bathroom every 2 to 3 hours, every 3 to 4 hours, something like that, so your body gets used to it. Then we have our minimally invasive therapies. So this one is becoming more common than just watch and wait, and also invasive. So this is kind of like the most common that you'll see in practice. So please review page 1257 in your textbook, table 54.3 on minimally invasive therapies. So the one we're going to talk about is an invasive therapy. It's called a transurethral resection of the prostate, or TURP. So maybe you guys have seen this in the patient's history of, past surgical history of having a TURP. Okay, so it is the gold standard, still currently the gold standard for obstructing BPH. You can see the way that it's done here. They're going to insert a scope into the urethra, go down into the bladder, and reduce that prostate. Okay, so what do you need to know? Post-procedure, the patient will have a 3-way indwelling catheter, and we'll see what that is on the next slide. It's going to have a pretty big balloon. We're used to a 10 ml for our regular Foleys, but this one is going to have a pretty significant balloon. And the balloon is actually going to help with clotting and to help with urine drainage. Okay, so if you imagine that, they just had this pretty significant procedure. This indwelling catheter is going to go in, and there's going to be a big balloon here, so it kind of helps put a little pressure there for bleeding, and it also creates a pathway for urine. Okay, so post-procedure, these patients may need continuous or intermittent irrigation for the first 24 hours. Okay, and then we'll talk about the reasoning on the next slide. They can develop as a side effect of that irrigation, they can have nausea, vomiting, confusion, bradycardia, and hypertension. So the irrigation fluid that they use in that can actually cause some imbalances. So the fluid goes into the bladder, and the bladder kind of absorbs some of that. It takes some of that solution in, and that can disrupt some people's electrolyte imbalances, causing these signs and symptoms. Not that common, but just be on the lookout. So we also want to look out for bleeding and clot retention, which is why we do this irrigation. So this is continuous bladder irrigation, or CBI, and the whole point is to remove clotted blood from the bladder and to make sure that that urine comes out of the bladder. Okay, so let's start over here. So this is what a three-way indwelling catheter looks like. So we have our balloon here, and then we have our drain, and we have our in-way, out-way, and then our balloon port. So this can be done either manually or continuously. I've never seen it done manually. That is very time consuming. That's like a one-to-one patient. However, I have seen continuous. Okay, so continuous is usually with normal saline, so normal NS or some other type of solution, but it's typically NS. Manually, we're just going to talk about CBI. Okay, so continuous. So you have this really big bag, okay, of irrigation fluid. You're going to hook it up, okay, and you're going to continuously monitor the flow. So you're going to adjust the drip rate until we get the color that we want output. So at first it's going to be bloody looking because you just had the procedure, but actually over time it should turn to a pink color, and you want to make sure that there are no obstructions in that tube from blood clots. If that happens, can you imagine what would happen? So you have this blood clot blocking the outflow, you have this irrigation infusing into the bladder, so the bladder is going to get huge. So we want not to do that. That can cause a lot of problems. Okay, and we should definitely stop and call the doctor if that happens. Okay, these patients may benefit from antispasmodics and pain medication as needed. Again, we're going to monitor for blood clots and stop and tell the doctor if it happens. After this is removed, once that catheter is removed, you want to teach the patient to do Kegel exercises that will help strengthen those muscles, since that tube can possibly have temporary like dribbling incontinence, so Kegel exercises are encouraged. And then you just want to give general care instructions if the patient is discharged with that indwelling catheter. Next, we have prostate cancer. So just like any other gland or organ, the prostate can also get cancer. This is the most common cancer among men, excluding skin cancer, and the second leading cause of cancer death. So risk factors for prostate cancer are going to include age, ethnicity, and family history. We have possible risk factors: good old diet, obesity, environment, and smoking. Okay, we're familiar with those. And then, although there is a genetic link, it does run in families, there is no specific test to see if the patient has a predisposition for it. All right, so signs and symptoms. Early, there are going to be no symptoms. Patients will be asymptomatic. When they do start to begin to have symptoms, they're going to have LUTS. LUTS refers to lower urinary tract symptoms, so very similar to BPH, so like difficulty urination, difficulty starting the urine stream, no force with the urine stream, dribbling, etc. And then symptoms of metastasis, generalized cancer, like generalized pain, anorexia, stuff like that. Okay, diagnostic wise, we're going to get a PSA screening. That's that blood test. We're going to have a DRE. We're going to do biopsy because that's the only definitive way to diagnose cancer. If the cancer has metastasized to the bone, then these patients will have an increased or elevated alkaline phosphatase. Okay, we can do imaging such as a whole body bone scan, CT, and MRI. That is just to see if that cancer has spread and just general severity of the cancer. All right, so of note, we are talking about that PSA blood test. We use it as a tool to see if there's issues with the prostate. However, it's important to note that just because that level is high does not mean it equals cancer. So there are lots of things that can cause an elevated PSA. For example, Mild elevations can just occur with aging. So if you're an older patient, you just may have an elevated PSA but not really have any other issues. BPH can cause it to be elevated. If you have ejaculated recently, you can have an elevated PSA. If you have acute or chronic prostatitis, or even after a long bike ride, all of those things can cause an elevated PSA, which again, PSA level on its own is inconclusive. You need to gather more clues to point you in the direction of what you're looking at, and in this case we're talking about cancer. Okay, so transient elevated levels of PSA happens after procedures like cystoscopy, indwelling urethral catheters, and prostate biopsies. So the treatment for cancer is like any other cancer. We want to remove what we can via surgery, and then patient will probably have combination of radiation and chemotherapy. The surgery of choice for prostate cancer is a radical prostatectomy, and what we need to know is the two different approaches that are used. So here at the top you see retropubic approach, and then we have our perineal approach. So the perineal approach is going to have more risk for infection just due to its location, so you want to remember that. All right, so post-operatively, these patients are going to come out of surgery with an indwelling urinary catheter. The balloon is going to be a bigger balloon than you're used to. It's going to be about 20 to 30 mLs. So that balloon actually helps to put pressure on the inside at the surgical site, and then it keeps urine flow unobstructed. So there may be a surgical site drain, so you'll have to teach the patient about that. We want to make sure, of course, to monitor and prevent infection. And then the patient's going to be in the hospital for about 1 to 3 days. So some common complications from this radical prostatectomy is going to be erectile dysfunction, incontinence, and then some other not as common than erectile dysfunction incontinence is going to be bleeding, seroma, lymphocyl, urinary retention, infection, wound dehiscence, and blood clots. Okay, so all of those things you should be aware of. Brachytherapy is also an option. Remember, that's a type of radiation therapy where they're able to insert and implant seeds, little radioactive seeds that emit radiation very, very close or inside wherever the cancer is, so that can also be used. Also, when patients have prostate cancer, an orchiectomy might also be beneficial. So this is the surgical removal of the testes. This may be done with a prostatectomy, or they may do it to shrink the prostate to relieve urinary obstruction in the later stages. This is a gold standard for androgen deprivation. The reason it's considered the gold standard is because there's really no side effects. It doesn't cost a lot to remove the testes. It is permanent, but it actually also facilitates cancer control, and it relieves bone pain in advanced stages of prostate cancer. Now let's talk about prostatitis. So prostatitis is an umbrella term, and it kind of refers to a group of inflammatory and non-inflammatory conditions that affect the prostate gland. So prostatitis is one of the most common urologic disorders, and there are millions of men who are treated for prostatitis every year. So if you look at this picture, the one on the left is a normal looking prostate. The one on the right is inflamed, red, swollen. All right, so we have 4 categories. We have acute bacterial, we have chronic bacterial, we have chronic prostatitis along with chronic pelvic pain syndrome, and then we have asymptomatic inflammatory prostatitis. So for acute and chronic bacterial prostatitis, we are dealing with bacteria. So the bacteria makes its way to the prostate via maybe from the urethra, maybe from the bladder, maybe it's in the bloodstream, or it's in our lymph system. So no matter how it gets there, it gets in and it starts to cause infection. So with chronic bacterial prostatitis, It is the same as acute, however, it just keeps coming back. It has recurrent infections, and this is going to be the most common cause of recurrent UTIs in men. Okay, so moving on to chronic prostatitis and chronic pelvic pain syndrome. So this is a syndrome. So when you hear the word syndrome, you think it's a group of manifestations. And this is relating to the prostate and having urinary pain in absence of an obvious infectious process. So the male comes in and says, I have a lot of pain when I urinate, or maybe, a lot of those lower urinary tract symptom pain, but they can't find any infectious process. So they're just going to say this is chronic prostatitis, chronic pelvic pain syndrome. They can't figure it out. Then we have asymptomatic inflammatory prostatitis. So this is when there is an inflammatory process present, but there are no symptoms. They're going to find white blood cells in seminal fluid. That's obviously coming from the prostate, but it's not really known what's going on here. So manifestations of acute prostatitis include fever, chills, back and perineal pain. They're going to have pain with urination, frequency, urgency, cloudy urine. A lot of this is going to mimic a UTI. Acute cystitis is uncommon in men, just FYI. These patients can also experience acute urinary retention. And then when a DRE is performed, the prostate's going to feel swollen, tender, and boggy. Okay, again, digital rectal exam. You can feel the prostate that way. It's going to feel swollen, tender, and boggy. Manifestations of chronic bacterial prostatitis, okay, and bacterial prostatitis and pelvic pain syndrome. Irritative voiding symptoms, so you can refer back to that BPH slide with all the description of the irritative voiding symptoms. Backache, perineal and pelvic pain, and ejaculatory pain. That digital rectal exam is going to show the prostate is enlarged, soft or boggy, and slightly tender. Okay, and again, mentioned it before, chronic prostatitis can lead to recurrent UTIs in men. Okay, complications, epididymitis and cystitis. Okay, sexual dysfunction, post-ejaculation pain, libido issues, and erectile dysfunction. Abscesses are rare. We're going to do urine and CNS, culture and sensitivity. We're going to check the white blood cells, blood cultures, that PSA blood testing. We can do a prostatic secretion culture. And then we can do a transrectal ultrasound, that's what TRUS is, or MRI, to rule out an abscess. So treatment, this is related to bacteria, so we're going to give them antibiotics. It can be oral or IV, just depending on how severe the infection is. If it is an acute bacterial infection, they can be taking antibiotics for up to 4 weeks. However, if it's chronic, they're going to take it longer, 8 to 12 weeks, or for a lifetime if the patient is immunocompromised. Okay, pain management. So the pain will usually subside when the infection is gone. Okay, for chronic prostatitis and chronic pelvic pain syndrome, that pain can go on for a while, so weeks to months. We can use anti-inflammatories such as NSAIDs, ibuprofen, and naproxen. Warm sitz bath can be soothing. Adrenergic blockers like Flomax can also help. Repetitive prostatic massage. Okay, repetitive prostatic massage can also be soothing. And then ejaculation relieves pressure in the prostate, so that can also help with pain and discomfort. So for acute prostatitis, these patients can experience acute urinary retention. So all of the urine is not coming out when the patient voids. So these patients may need a temporary suprapubic catheter inserted. The reason why they don't put in a Foley is because that is contraindicated in patients with acute prostatitis. We want to make sure these patients are hydrated. We don't want that urine in the bladder to become stagnant and concentrated, because that can harbor bacteria and create another problem. So we want the patients to keep hydrated, lots of fluids, and we want to monitor for fever. Okay, so let's talk about erectile problems. So priapism, we had talked about this when we were talking about sickle cell disease. So priapism is a painful erection greater than 4 hours. It is considered a medical emergency because there is some type of obstruction going on of blood flow. So without adequate blood flow, meaning not enough oxygen is going to go to the cells and tissues, we're going to start to have ischemia, cell death, and possible necrosis. So that is what we want to avoid. So associated conditions with priapism include sickle cell disease, diabetes, spinal cord trauma, degenerative spinal lesions, medications. Medications such as vasoactive drugs that are actually injected into the corpora cavernosa for erectile dysfunction. So this can happen as a result of this medication being used. So some complications, like I said, penile tissue necrosis, that would be related to obstruction, or even hydronephrosis. Again, it is all related to obstructed venous outflow. So treatments will just depend on whatever's causing it. If it's sickle cell, then the patient will probably need some type of blood exchange transfusion. Some other options could be sedatives, smooth muscle relaxant injected into the penis, and actual aspiration and irrigation of that corpora cavernosa. So you can take a look at the picture here. They all look quite invasive. Next up is Peyronie's disease. So this is when there's plaque formation right here in the corpora cavernosa, okay? And this is going to result in less elasticity, and it's also going to result in curvature when the patient has an erection. You can see it here in the picture. So this can occur spontaneously or due to trauma. It can be painful and obviously could be embarrassing for the man, but it's not dangerous. So there are some medications that can be injected that can help out with that. And then surgery is also an option. Okay, moving on to the scrotum and the testes, inflammatory and infectious problems. So here we have epididymitis. We've talked about this one, so let's see what it is. So epididymitis is acute, painful inflammation of the epididymis. So the epididymis is a long, you see it here on the left side, a long coiled tube that rests on the backside of each testicle. And the function of it is it carries and stores sperm that are located in the testes. So causes of this inflammation include infection, trauma, urinary reflux. It's usually only going to affect one side, so unilateral swelling. If the patient is under 35, many times the reason is going to be gonorrhea or chlamydia. Okay, we talked about STIs, so there you go. If the patient is over the age of 35, we can suspect E. coli, BPH, or prostatitis. So the treatment for this, if it's an STI, is going to be antibiotics, condoms, and education to abstain from sex. And then conservative, so without medication, we can elevate the testes, we can use cold packs, and then pain medication. Next is orchitis. This is inflammation of the testes. So with this one, we're going to have all of those inflammatory signs and symptoms like pain, tender, swollen, redness, warmth. This usually occurs after a bacterial or viral infection. It could be a side effect of epididymitis, trauma, mono, the flu, maybe a Foley, so a catheterization, UTI, or mumps. If it is a result of having mumps, it can possibly lead to infertility. So we have a vaccine for mumps, so we want to educate on that for this one. And then the treatment is going to be similar to epididymitis, so antibiotics. All right, so congenital problems of the scrotum and testes. So congenital means the patient is born this way. And we have cryptorchidism. This is undescended testes. So you can see here in the picture, the testes should actually be down here, but they are not there. So this is the most common congenital testicular condition, and usually the undescended testicle is on the right-hand side. Okay, so usually it's on the right-hand side, but it can be bilateral or it can be on the left side, but normally it's only on the right side. All right, so what we're going to do is corrective surgery. So we want to locate it and then bring it back down where it should be and then suture it in place. So normally this is found when the patients are young, so below the age 2. So if this is corrected by then, it will reduce the risk of infertility. Okay, and it should be done because it also reduces the risk of cancer. So we do want to correct this. Acquired problems of the scrotum and testes. So now we're going to talk about a hydrocele. So a hydrocele is a non-tender fluid-filled mass from altered lymphatic drainage of the scrotum and swelling of the tunica vaginalis that surrounds the testes. So a hydrocele can develop as a result of injury or inflammation from within the scrotum. The inflammation could be caused by an infection in the testicle or inflammation of the epididymis. All right, so how are we going to diagnose it? Via transillumination. They're going to shine this big light against the testes, and you can see that big fluid-filled mass. So treatment is not necessary unless it is large and uncomfortable. So in practice, I've seen very, very large hydroceles. Usually the patient is in ICU, and they're very, very, very big. So if that's the case, the patient may need surgery. However, we want to avoid surgery because that can lead to infertility. Okay, so that's why they don't really do anything unless it's causing, a problem. Next is the spermatocele. So this is a firm sperm-containing cyst of the epididymis. And so here we have normal. Okay, and then we have here's our spermatocele right here. So this can be large, tense, and painful. They don't know why it happens. They think it might be due to a blockage in one of the tubes that transports the sperm. Spermatoceles, they are sometimes called spermatic cysts. They're pretty common, and they usually don't require treatment. It usually doesn't cause any infertility unless you do surgery. Okay, so we want to avoid it. It doesn't really harm anything. And again, surgery is very risky, and the surgery can cause infertility. Okay, then we have a varicocele. So this is dilation of the veins that drain the testes. So varices, varicocele, it's kind of like an engorged vein. So these are going to feel like little worms when you palpate them. We don't know why it happens. You can see in the picture here the normal, what it's supposed to look like, and here they're very engorged. So it's usually on the left side, and that's due to just the blood flow from the left renal vein. Surgery, if infertile, okay, 40 to 50% of infertility due to varicocele. So very high risk. Repair involves injection of a sclerosing agent or surgical ligation of that spermatic vein. Testicular torsion. So if you look in the picture, the whole spermatic cord that supplies blood to the testes and epididymis is twisted. So this twists and starts to cut off blood flow. So this is a surgical emergency. It's very common under the age of 20. It can occur spontaneously, trauma, or maybe an anatomic abnormality. So maybe you have somebody, playing some type of sport, and then all of a sudden they have this severe sudden onset of scrotal pain. It can be tender, there can be some edema, it can even cause the patient to be nauseated and cause them to vomit. So that can be quite painful. So there's not going to be any urinary symptoms or fever because you can see it doesn't involve anything having to do with the urethra. And the pain does not decrease with rest or elevation. So no matter what the patient does, the pain does not get better. That's why it's really important to ask those questions when you're obtaining a history and physical. That PQRST, what makes the pain better? What were you doing when you had the pain, etc. All right, so diagnosis, we're going to do a Doppler ultrasound. You must restore blood flow back to that testicle within 4 to 6 hours. Okay, and that way you'll avoid necrosis. Again, emergent surgery, and then sometimes it just corrects itself spontaneously, just out of nowhere. So keep that in mind too. Next is testicular cancer. So just like any organ, the testes can also get cancer.
So pathophys, this is the most common cancer in males aged 15 to 44, so very common. This is more common with patients with cryptorchidism, okay, that's with the undescended testicle, or family history or anomalies. So some predisposing factors are orchitis, HIV, maternal exposure to estrogen, and if they already have cancer in the other testes, okay, all of that puts them at higher risk for getting testicular cancer. So clinical manifestations, it can be slow, it could be fast, it just depends on the type of tumor. These patients are going to have a painless lump in the scrotum, okay, and it will become edematous and it'll just feel heavy. There'll be a scrotal mass, but it's non-tender, meaning it's not going to be painful, but it will be firm. They'll have a dull ache or heaviness in the lower abdomen, perineal area, and scrotum, so just generalized pain. At first, 10% of the patients will experience acute pain. As the disease advances, they're going to experience lower back pain, chest pain, cough, and or dyspnea, shortness of breath. So with any cancer, the treatment #1 option is going to be surgery. So radical inguinal orchiectomy. So that's surgical removal of the affected testes, the spermatic cord, and the regional lymph nodes. Okay, you can see here in the picture. Cancer. Okay, if it's in the early stage, then no other treatment is required. After this surgery, okay, post-orchiectomy, we need to make sure we maintain surveillance, meaning that patient needs to come back and get routine checkups, and or the patient may also need some radiation or chemotherapy, just depends on how severe that cancer was. Okay, retroperitoneal lymph node dissection after chemotherapy in advanced disease. Okay, so they remove those lymph nodes. Medications for testicular cancer, they're very potent. They have many side effects. So you can read through here: pulmonary toxicity, kidney damage, nerve damage, hearing loss. So lots of side effects. Follow-up care for testicular cancer, surveillance. Just like any cancer, it can come back at any time. So we want to make sure that they get regular physical exams, chest x-rays, and tumor marker blood work. So the treatment can cause issues with fertility. So before we start it, we want to ask the patient, about their family planning goals. Do they plan to have kids in the future? Should we freeze those sperm? So that should be a conversation. And then ejaculatory dysfunction may threaten masculinity and self-worth. So just keep that in mind. There is a psychosocial aspect of this. All right, so now let's talk about a vasectomy. So a vasectomy refers to a surgical ligation or resection of the ductus deferens for sterilization. So these patients don't want to have any more children. Okay, so that is the purpose of a vasectomy. So this is actually very quick. So it's local anesthetic, it's outpatient procedure, meaning they just come in for their appointment, get it done, and leave. It takes about 15 to 30 minutes. All right, so after the vasectomy, the patient will have ejaculate that is similar to look and feel. So this vasectomy doesn't affect hormone therapy, which is nice. It also doesn't affect the ability to ejaculate, okay, or to have an erection or to orgasm. So all of these things are very important because when a patient has these type of surgeries, they have anxiety that it's going to change them, they're not going to be masculine anymore, etc. So the psychosocial adjustment, just make sure you keep that in mind. And then a vasectomy, we want to continue to use other methods of birth control for the first 6 weeks, just to make sure that the vasectomy was successful. Okay, so again, patients should be instructed to use birth control for 6 weeks after a vasectomy. Next is erectile dysfunction, or ED. So this is the inability to attain or maintain erection that allows for satisfactory sexual activity. So satisfactory is subjective, so it's whatever the patient's, wanting. So in the US, there are more than 10 million people who have erectile dysfunction, and the incidence increases with age. Okay, so ED results from reduced blood flow to the penis, and there's lots of different reasons. So the underlying cause for some men may be normal physiologic age-related changes. So what that means is as a man grows older, they may just develop this erectile dysfunction. It's kind of like it's a normal physiological process related to age. Risk factors, okay, so all of those things that interfere with circulation, so diabetes, vascular disease, some medication. It could be the result of a different surgery, okay, erectile dysfunction as a complication of another surgery. Trauma, chronic illness, stress, if you have relationship issues, that might affect your ability to attain or maintain an erection. And then depression. So please read this table in your textbook for more information. All right, so clinical manifestations are easy. The patient is just going to report that there's something wrong, some type of erectile dysfunction. It can be occasional, it can be continuous, it can be in reaction to something. So those are all questions that we want to ask. Complications are going to really be more related to psychosocial, so distress in their relationships, their own self-concept. Many believe that having a erection and being able to, have kids, that kind of stuff signifies that you're an actual man. So if you're not able to do that, it can really alter your self-concept. There can be anger issues, anxiety, and depression. Okay, so in younger men, erectile dysfunction, if you have like a young person, they don't necessarily fit the mold. So these patients will most likely have some type of substance abuse or some type of stress or anxiety in their life, and that is why they have this ED. In middle-aged men with no chronic medical conditions or treatments for these, so chronic conditions or treatments for those conditions can cause erectile dysfunction as well. Diagnosis of erectile dysfunction is going to rely heavily on the patient's subjective data, so what they're complaining of. But we do want to get lots of information related to their sexual history, generic health history, and psychosocial history. Once we get that, then we will determine which lab tests are appropriate to run. So some commonly ordered labs related to erectile dysfunction could be blood sugar, A1C, and lipid panel, hormone levels, PSA level, and a CBC. Other other non-invasive approaches would be nocturnal penile tumescence and rigidity, and then penile arteriography and vascular and duplex Doppler ultrasound to assess blood flow. That's the one that you'll see most common. Managing erectile dysfunction. So the goal would be for the patient and their partner to achieve a satisfactory sexual relationship, and that is subjective to what they think, right? Okay, so we want to identify the cause and determine if it is reversible, because if it is not reversible, then we don't want to give false hope. If the patient has some psychologic issues, we can refer them out to a therapist for counseling. And then we do want to provide emotional support, make sure they know that things are confidential. Patients are kind of in distress when they come to report this, and they may be looking for a quick fix, but we just want to support them and be transparent. So erectogenic drugs, so these are medications that facilitate an erection. So these PDE5 inhibitors here are the ones of choice. They should be taken orally before sexual activities. Here are some examples of those. Side effects include headaches, back pain, dyspepsia, flushing, nasal congestion. This can lead to blurred or blue-green vision, sudden hearing loss, priapism, and again, for priapism, they should seek medical attention right away. All right, so for these erectogenic drugs, these patients should avoid medications with nitrates, because that can cause a hypotensive effect. So again, erectogenic drugs, you need to keep them away from drugs with nitrates. Okay, other management of the ED include vacuum erection devices, intraurethral devices, and injections, penile implants, and then alongside all of these things are sexual counseling. So sexual counseling can be started at any time during erectile dysfunctional management. It is most valuable in cases with psychogenic ED, and this is because it addresses psychologic or interpersonal factors that can be affecting, erectile dysfunction. And then, of course, these counseling sessions can include the partner. Sometimes that's beneficial, sometimes it's not beneficial. Now we're on to hypogonadism. So hypogonadism is the gradual decline in androgen secretion as men age. Okay, so this is age related. And the primary hormone we're talking about is testosterone. So this is also called late onset hypogonadism or hypogonadism of old age. So it typically starts at about age 40, and the cause is unclear, but they know that obesity is a contributing factor. So if you look at this first little table here, you can see that testosterone declines as we age, so this is tied to hypogonadism. So clinical manifestations are going to be decreased libido, fatigue, erectile dysfunction, depression, mood swings, and sleep problems. So diagnostic wise, we're going to do a physical exam, blood test, and we're going to check those testosterone levels. So treatment is going to include testosterone replacement therapy, TRT. So some contraindications are going to be unmanaged BPH or prostate cancer, okay, because testosterone is contraindicated with those conditions. So we can give testosterone in the form of injection, transdermally, topically, buccal, that's like in the cheek, intranasal. There is an oral form that exists, but that has not been approved in this country. So women of childbearing age and children should avoid contact with testosterone products because if it is absorbed through the skin, touching the medications, it can cause early signs of puberty and changes in external genitalia in the female fetus. So we want to avoid that. And finally, our last slide is infertility. So this is just a basic slide on infertility. So the definition of infertility is the inability to conceive after 1 year of frequent unprotected intercourse. All right, so some infertility causes in males. This would be hypothalamic pituitary system problems, testicular disorders, and problems of the ejaculatory system. So they're categorized into 3 physical causes, including pre-testicular, testicular, and post-testicular. Really just depends on what the cause is. So diagnostic-wise, we're going to test the semen, we're going to test hormones, and actually both partners should be have an evaluation to see, because it might not be the male, it could be the female, or vice versa. So might as well just test them both so they can get a baseline. So treatment options, medications, maybe some lifestyle changes, IVF or in vitro fertilization, corrective surgery if that is what's causing it, and then counseling because infertility can cause major strain on relationships. So counseling will help discuss that, and then also maybe some alternatives to, if they're trying to get pregnant, maybe adoption, surrogacy, something like that. And that concludes this chapter.